Well, it's my pleasure to be discussing the issues around screening for anal cancer, and specifically whether we're making a difference with the implementation of anal pap smear screening in populations at risk for anal cancer. My name is Joel Palevsky from the Department of Medicine at the University of California, San Francisco, and I'm the director of the UCSF Anal Neoplasia Clinic, which has been in operation for about 20 years now, which was based on the idea that we should be able to prevent anal cancer in a manner similar to the way that we prevent cervical cancer, namely screen with tests such as cytology, followed by visualization of abnormal areas seen through magnification and vinegar and other tests made possible with the use of a colposcope, followed by treatment of precancerous lesions, which may then hopefully reduce the risk of progression of those lesions to invasive cancer. So the outline for my presentation is that we're going to be discussing the rationale for doing this in the first place, which is the changing incidence of anal cancer. I'll describe the epidemiology of anal HPV infection and anal intraepithelial neoplasia, or AIN. And then we'll talk about the methods that are currently available to prevent anal cancer, both primary prevention and secondary prevention methods. So first we need to talk about the agent that is the cause of this problem, and that is human papillomavirus, or HPV. This is the same virus that causes cervical cancer and genital cancers in other locations as well, such as a proportion of penile cancers, vulvar cancers, and a growing proportion of oral cancer. There are over 100 different types of HPV, and some of these are believed to be oncogenic, whereas others are not. On this slide, you can see the list of the most important oncogenic HPV types, or cancer-causing HPV types. And type 16 is made larger than all the others because in many ways this is a type that is in a class by itself. It alone accounts for more than 50% of all cervical cancers and a very high proportion, even higher in fact, of anal cancers. Type 18 is the second most common oncogenic HPV type, and in the case of the cervix, accounts for another 20% or so of those cancers. So between type 16 and 18, we have about 70% of cervical cancers, and for anal cancer, well over that. There are, however, other oncogenic types that cause cancers at these locations, and these are listed here. They include 31, 33, 35, 39, 45, some of the 50s, and type 70 may be considered, in some cases, oncogenic as well. The non-oncogenic types are listed here. These are just some of them, but these are probably the most important ones from a clinical standpoint. Of these, type 6 and 11 are important because they are the types that cause most genital warts, and types 1, 2, and 4 are the causes of most plantar or palmar warts. So what happens when HPV actually infects the epithelium? Well, firstly, as you can see on this slide, the typical target for HPV is a well-stratified squamous epithelium. The cells, of course, sit on the basement membrane, the basal layer, and these are the cells that generate the rest of the epithelium, so that when these cells divide, the cells mature and move up through the epithelium, such that the epithelium is really in a constant state of turnover, kind of like a snake skin. To go from the basal layer all the way to the surface may take about 30 days or so. The target of HPV is actually the cells in the basal and parabasal cell layer, because these are the cells that generate the rest of the epithelium. They are dividing, and they are actually a more or less permanent reservoir of HPV infection. To get through all these layers of epithelium, HPV needs to have some sort of a tear or a rent in the epithelium to allow the virus to get through the upper layers. And when HPV gets down there, it typically begins by dividing as the cells divide, but has relatively little viral protein production. Then, usually, as the cells mature, they stop dividing, but the virus doesn't. And in the more mature cell layers, one tends to see higher levels of viral production. And finally, the formation of full virions, where the viral genome is encapsulated by the viral capsid made up of the HPV L1 and L2 proteins. And when one forms these full infectious virions, these are the infectious form, and when the cells slough off, they probably carry infectious virion with them. So the reason that certain kinds of epithelium are more susceptible to others, amongst many reasons, is the fact that some epithelia are easier to penetrate to allow HPV to get down to the basal layer. For example, as I'll show you on the next slide, the cervical transformation zone is rather thin and highly metabolically active and susceptible to other sexually transmitted infections, such as gonorrhea and chlamydia, which can disrupt the epithelium as well. This will allow HPV to get down to its basal layer targets. A similar areas I'll show you is in the anal canal, where two different kinds of epithelium in the squamous exoanal area versus the columnar epithelium of the rectum meet at the anorectal junction. So, looking at what actually happens when HPV infects, you can see that on the left, one sees normal epithelium. And in fact, the great majority of people, men or women, who get HPV infection never have a clinically detectable lesion. It is thought that actually 75 to 80% of all sexually active adults will get a genital HPV type, and we know that a much smaller proportion than that actually develop disease. What may in fact actually be happening, though this is a bit of speculation, is that everybody develops a lesion. The most common of these is shown on the left side of the slide, which is now put into the basket of low-grade disease. This includes condyloma or warts and cervical intraepithelial neoplasia, or CIN, and AIN grade 1, also known as very mild to mild dysplasia in the older terminology. This is a lesion that is the most common abnormality associated with HPV, and it is not thought to be precancerous. Most of these times, these lesions will regress spontaneously, and it's possible that many of the people who never have a detectable lesion may in fact have had a low-grade lesion at some point, but due to the development of a cell-mediated immune response to HPV, actually regresses before the person next comes to the attention of their clinician. So having a low-grade lesion is the better of the two to have if you have to have one, because these are not considered directly precancerous, in contradistinction to the high-grade lesion shown on the right side of the slide, which has the basket right now of CIN or AIN grade 2 and grade 3, also moderate, severe, and carcinoma in situ are other terms used to describe the high-grade lesion. In contrast to the low-grade lesion, this lesion is considered to be potentially precancerous, and in fact, the focus of the cervical pap smear screening system is to identify women with this lesion so that it can be detected and treated before the lesion progresses to invasive cancer, which is depicted at the bottom part of the slide on the right, where the cells cross the basement membrane, enter the stroma, where they may cause morbidity and eventually mortality by blocking local vital organs or by metastasizing to distant organs. So the pap smear is really designed to pick up the high-grade lesion, and colposcopy in the cervix or high-resolution analoscopy in the anus are designed to pick up high-grade disease in the anus. Those lesions are biopsied, and then the lesions with high-grade areas are ablated to prevent that progression event. The time taken to go from the high-grade lesion to invasive cancer is highly variable, but in fact may take many years and in some cases decades. What is actually happening during this time is not entirely clear, but it may be that one over time accumulates genetic mutations, which are the result of some of the HPV proteins, such as E6, which causes genetic instability. And once one gets just the right or wrong combination of genetic changes, that may be enough to trigger that switch to cause invasion. The good news about the time taken for that point to be reached is that it does give clinicians several opportunities to detect that lesion before the progression event occurs. This is really helpful because both in the cervix and the anus, the sensitivity of the screening tests, such as cytology, is rather low, in many cases as low as 50%, which means that if a woman or a man has a lesion, about 50% of the time when they have that lesion, that pap smear is going to come back negative. The reason the cervical system works as well as it does to prevent cervical cancer is that we repeat those Pap smears at certain intervals, and it is a cumulative sensitivity of those tests that allows us, in most cases, to pick up the lesion before it can progress to cancer. In all likelihood, the same is true in the anal canal. Now, as I said before, in the cervix, the area that is particularly susceptible to HPV is shown here, and it's called the transformation zone, where one has the squamous epithelium of the exocervix meeting the columnar epithelium of the endocervix, and in between is an area that is constantly moving and thin and susceptible, as I've said, to other infections. This is where the majority of HPV infections occur. This is where the majority of CIN lesions arise and where most of the cervical cancers arise. It turns out, though it's not entirely obvious, that the anus has a similar area. Here it's where the squamous epithelium of the anal canal meets the columnar epithelium of the rectum, and that anorectal junction is very similar biologically to the cervical transformation zone. Consequently, this is where a very high proportion of the anal HPV infections occur, where many of the AINs arise, and where many of the anal cancers also arise. This isn't to say that one doesn't get any of those things perianally, because of course you can, but much of the action is internal where it can't be seen. The way to determine what's going on is to do tests that allow us to sample the epithelium internally, because it's not sufficient to simply spread the patient's buttocks and take a look with the naked eye. One of the easier ways to do that is to do the equivalent of cervical Pap smear. We call that anal cytology, and we'll come back to that a little bit later when we talk about some of the screening tests for AIN. So, why all the fuss? The main reason is because anal cancer is increasing in incidence by about 2% per year in the general population since the 1970s. That's true in both men and women in the general population, and it surprises a lot of people to actually learn that females are more likely to get anal cancer than men. Anal cancer is more common in women than in men in the general population, and that's true in almost every developed country where these data are collected. So the incidence of anal cancer is going up, and in all likelihood, although still not yet proven, anal cancer, like cervical cancer, is preventable. So for these two reasons, plus the fact that certain populations are at particularly high risk, that we believe that a program to investigate the possibility of AIN followed by treatment to prevent progression to cancer may be highly beneficial to those populations. So let's talk about those populations. So anal and cervical cancer incidence, just to put it in the context of cervical cancer, is particularly common in men who have sex with men. Before we were doing routine cervical cytology screening, the incidence of cervical cancer was about 40 to 50 per 100,000. Now, since we've done Pap smears and followed them up with the treatment of the high-grade CIN lesions, the incidence of cervical cancer is now down to about 8 or so per 100,000. If you look, however, at an unscreened population, which are MSM, unscreened for anal cancer, you can see that even before the HIV epidemic, the incidence of anal cancer was estimated to be as high as 37 per 100,000. That puts it actually in the same ballpark as cervical cancer was before we were doing routine cervical cytology screening. Now, as I mentioned, this is before the HIV epidemic began, and one becomes concerned about the additional impact of HIV-related immune suppression. As you recall, we said that for lesions to regress, one needed to have the institution of a cell-mediated immune response to fight off the HPV-infected cells. So if you lose that HPV response, then one might imagine that you'll be at even higher risk of HPV-related consequences. This slide shows what happened when the HIV epidemic began, but before there was widespread introduction of antiretroviral therapy. As you can see in the red circles here, the incidence of anal cancer is remarkably high and quite a bit higher than in the general population among HIV-infected men, 37.9-fold overall, and also in HIV-infected women, almost 7-fold higher than the general population of women. If you look a little more carefully at the column of men, you'll also see that the risk amongst men is not equally distributed, The highest risk is in those who report a history of homosexual contact, and that's presumably because they acquired HPV in the anal canal through receptive anal intercourse. However, you'll also see that heterosexual men who acquired HIV through injection drug use had a significantly increased risk as well, implying, as you might imagine also from the female data, that having anal intercourse is not the only way to get anal HPV infection. After looking at a lot of studies, not all of which have consistent results, we've come to the conclusion that having anal intercourse is perhaps the most efficient way to get anal HPV, but not necessary. HPV can also be spread through fingers, toys, and potentially from other genital organs. So this again is what we saw before the introduction of antiretroviral therapy. The question then becomes, okay, people go on antiretroviral therapy, what's going to happen to the incidence of anal cancer? As you know, many HIV-related malignancies have gone down in incidence since antiretroviral therapy came on the scene. Classic examples of this are non-Hodgkin's lymphomas associated with Epstein-Barr virus, and of course Kaposi sarcoma associated with HHV-8. When you look at the natural history of HPV, however, one might imagine a different outcome. This slide shows what happens as a function of increasing immune suppression. Typically, most people will get their HPV infection early on after initiation of sexual activity. We know from women's studies, for example, that many women get their HPV within their first 2 or 3 sexual partners. At some point in time thereafter, not always, of course, but most of the time, they'll acquire HIV after they get HPV, but they may certainly continue to get additional HPV types with new sexual contact. As they remain relatively immune intact, there is relatively little viral replication as shown by the yellow lines on the left side, and relatively little disease. But with increasing immune suppression in the absence of an intervention such as antiretroviral therapy, one may see higher levels of viral DNA replication, that is HPV, shown with the higher yellow lines on the top, and progression to high-grade disease. It's been quite clearly shown that progression to high-grade disease is related to immune suppression, at least as measured by CD4 level. However, going from high-grade disease is more complicated when it comes to progression to cancer. Here, the relationship is not as clear to measures of immune suppression, such as CD4, and it may be that genetic changes, such as the ones we discussed earlier, may be more important, and that you reach a certain point in the biology of high-grade disease that no amount of immune reconstitution is going to cause that lesion to regress. Now, you may say, if that is true, why didn't we see increased rates of anal cancer even higher than we did in the past? And one of the reasons is because it takes potentially many years or decades to go from high-grade disease to cancer. And before we had antiretroviral therapy, individuals often died of competing causes and didn't have the opportunity for high-grade disease to progress to cancer. If that is in fact true, and if it is also true that immune reconstitution is not going to lead to regression of high-grade disease, then one might imagine that if you start a person on antiretroviral therapy, they will benefit greatly by having greater survival. They're going to live longer, which also gives them more time to progress to cancer, particularly if they are not being actively screened, which is still the case for the great majority of people who are potentially at risk for anal cancer. So this creates, if you will, kind of a perfect storm. People living longer, healthier lives by most measures, which is a wonderful thing, but who have now increasing time for a potentially precancerous lesion to progress to cancer in the absence of screening. And so we actually predicted that when antiretroviral therapy became commonly used, that would actually result paradoxically in an increased risk of anal cancer rather than a decreased risk, as we've seen with some of the other infection-related malignancies. Unfortunately, that prediction has somewhat come to pass. Here are 3 relatively recent papers showing that the incidence of anal cancer in what we would consider to be one of the highest risk groups of all, HIV-infected men who have sex with men, have actually gone up since the introduction of antiretroviral therapy. ART in the United States became widely available in 1996. And here you see 3 different cohorts or studies showing rates as high as 75 per 100,000, 78 per 100,000, or 137 per 100,000. So these are numbers that are much higher than the incidence of cervical cancer, at least in screened populations, but are even higher than many of the highest rates of cervical cancer seen in countries around the world where there isn't routine screening for cervical cancer. The next slide shows that this has been confirmed in a study from the VA system, where if you compare the incidence of anal cancer in the post-HAART era to the pre-HAART era, one sees a five-fold increase, again suggesting that the incidence of anal cancer at a minimum has not gone down with ART and is more likely actually continued to rise. So the question is, if the incidence of anal cancer has gone up in the ART era, what do we know about the events that lead to this point, since we believe that there are potential points where one can interfere with this process? These are some data that I'm showing you, one of many studies, in fact, at this point, but fairly unique given that the data actually are population-based. It was a study that we performed a few years ago in San Francisco where we did random digit dialing and identified people randomly who were willing to come in and get anal cytology, high-resolution anoscopy, and biopsy, and who were willing to share their HIV status with us. As you can see on the top part of the slide, looking just at HPV infection, that amongst the HIV-positive participants, 88% had HPV overall, and this is all in the post-HAART era, and 72% had a cancer-causing HPV type. Amongst the HIV-negative men who have sex with men, 57% had anal HPV, and 34% had a cancer-causing HPV type. The bottom part of the slide is particularly important because it shows the prevalence of disease in this population. You can see that in the HIV-infected men, 57% had AIN of any grade, but 43% had a potentially precancerous lesion, a high-grade AIN lesion. Also surprising was that when you look at the HIV-negative men, 35% had AIN of any grade, and a quarter of them actually had a potentially precancerous AIN lesion. So these numbers show that in the post-ART era, consistent with the rising rate of anal cancer, that the prevalence of both HPV infection and AIN, particularly high-grade AIN, is very high, both in HIV-positive and HIV-negative men who have sex with men. A study that was reported recently is the SUN study, which was a national study in which they measured both anal HPV infection and disease using cytology in men who have sex with men, women, and men who have sex with women, all HIV positive. And I'm showing this to you to remind us that women are also at increased risk of anal cancer and AIN when they're HIV positive. So in this study, you can see that 35% of the women had abnormal anal cytology and 20% had AIN of any grade. Remember that the sensitivity of cytology is relatively low, so this is likely to be the low-end estimate of the true disease prevalence in women. You'll also notice, consistent with that 90% of the women had anal HPV infection. And in fact, we and others have shown that in high-risk women, both HIV positive and HIV negative, that the prevalence of anal HPV infection is higher than the prevalence of cervical HPV infection. So what I've told you up to this point is that there is a rising incidence of anal cancer in the setting of HIV infection, as well as other risk populations, and that the prevalence of anal HPV infection and AIN can be very high in these populations as well. So what to do? Well, we've been proponents of a screening system for at-risk patients, not for everybody, but for at-risk patients, using a screening method to triage people who need high-resolution anoscopy. One can, for example, do anal cytology, and our recommendation is to refer anybody who has an abnormal cytology for high-resolution anoscopy with biopsy, and then if they have high-grade on biopsy, to be treated. If they have low-grade, if they're symptomatic, they can be treated, or they can be followed since these are not considered to be precancerous. We've done cost-effectiveness studies and shown that people who have normal cytology can be rescreened rather in 12 months if they're HIV positive, and every 2 to 3 years if they're HIV negative. Now, it's very important to understand the difference between the cytology screening test and a cancer screening test. This slide shows a young man dressed in a San Francisco Giants shirt. And as many of you know, I'm from the San Francisco area here. This was when the Giants, this picture was taken when the Giants won the World Series, so I should probably remove this picture from the slide, but I think it's kind of cute. And what it shows is that the cancer screening test is really your finger. It is a digital anal exam. We don't call it a digital rectal exam. We call it a digital anal exam, or if you wish, a digital anorectal exam, or DARE. What we're doing is we're feeling for lumps or bumps underneath the surface where you might not even see it if you scoped the person, and that is often indicative of the presence of a cancer. This is something that we all know how to do, and it's a screening test for cancer that, in our opinion, should be done at least on an annual basis by all providers who care for HIV-infected men and women. Now, in contrast, everything that I've been telling you up to this point describes screening tests really for AIN. What we're trying to do is prevent the cancers. And so the goal of cytology is to find high-grade AIN and follow that by high-resolution anoscopy and the biopsies. You may say, why not just do high-resolution anoscopy and biopsy on everybody who's at risk? The problem is, as you now know, that a very high proportion of individuals have these lesions, and there's also, at this point, still a relatively limited number of people trained in high-resolution anoscopy. HRA is a skill like cervical colposcopy, and it takes sometimes several years to get really good at it. There's a learning curve. So it takes time to become a high-resolution anoscopist, and as you will see in a bit, it's important to have a complement of professionals from other backgrounds to work with to take optimal care of the patient. So basically what we do, given that the number of providers of HRA are relatively limited at this point, is use cytology as a kind of a triage test. Although we said to refer anybody who's got an abnormal pap smear, many people can't do that since even then there are too many for referral. And in that case, what we do is suggest triaging based on the grade of the cytology. We know that if somebody has a high grade on cytology, that there's a very high likelihood that they really do have a high-grade lesion on HRA and biopsy. And so we would recommend referring patients with a high grade on cytology first. Many patients with low grade on cytology also have high grade than those who have high grade on cytology. Therefore, we would recommend following all those who have high grade on cytology by those who have low grade on cytology, and then finally those with ASCAS. Patients who have a variant of ASCAS called atypical squamous cells cannot rule out high-grade disease, or ASC-H, also have a high risk of high-grade disease and should probably be referred for HRA and biopsy. So we think we're going to find a lot of AIN, and we have in every population at risk that we've looked for. And so the question is, what are we going to do to remove those lesions or at least reduce the risk of anal cancer? Just like in the cervix, there is no specific treatment for HPV, and therefore we use different methods to remove the lesions physically. If the lesions are small, we've actually shown that you can do a very simple and cheap treatment, which is apply 85% trichloroacetic acid in the anal canal, but that typically only works when the lesions are small, as defined by being less than 1 square centimeter at the base, and typically limited in number. And this also tends to work better with patients who are less immunocompromised or negative for HIV. Unfortunately, much of the time when we see patients, their lesions are too big for this or too numerous. And in that case, our approach of choice is to use a method called infrared coagulation. I'll show you a picture of the machine that we use in just a moment. But this is an office-based procedure, which is typically very well tolerated, and many patients get up off the table and go right to work after the procedure. I will say that this has not been approved by the FDA for this purpose. It is approved for the treatment of anal warts, but has not yet been subjected to FDA scrutiny for the treatment of AIN. It also has been approved for the treatment of hemorrhoids, so we believe that the treatment would work well in the anal canal. And in fact, 65% of patients are free of disease after a median of 413 days. Many patients actually need more than one treatment, but the treatments are well tolerated, and the cumulative proportion of people free of high-grade disease goes up with increasing numbers of treatments. Unfortunately, many patients have disease that's even bigger than that, and these are the patients who we send for referral for surgery to have the lesions excised in surgery, or we also refer patients who have lesions that are too big to be biopsied in the office, and they have an examination under anesthesia. Unfortunately, with surgery, the patients are often left with quite a bit of discomfort for sometimes several weeks after the surgery, and so we tend not to refer patients for surgery unless they meet these particular criteria. Occasionally, we have some patients who have so much disease that we can't do much other than to watch them very carefully, or sometimes we will apply 5-FU cream, Effudex, to try and reduce the disease burden. Again, this has not been approved by the FDA for this purpose. So here's what the machine looks like. And again, just to reiterate, this is not FDA approved for the treatment of AIN. But in our experience, it's been shown to be quite safe and at least as effective as the other methods that are available. Typically what we do is we do the high-resolution anoscopy, we insert the anoscope, and then we apply the tip of the black probe shown here to the lesion and deliver a pre-specified amount of infrared energy which ablates the lesion. So who should you think about as far as deciding who to screen and ultimately to treat if you find a high-grade lesion? Here's our list. It includes HIV-infected men who have sex with men who have a good prognosis, HIV-uninfected men who have sex with men over the age of 40. We don't believe that it's necessary to screen or treat young people who are otherwise healthy for the prevention of anal cancer, and here I'm defining older as being over the age of 40. So there's no need to screen 20-year-olds or even probably 30-year-olds. We think that women with a history of high-grade cervical or vulvar disease or cancer should be considered for screening. There are data suggesting that those women are at increased risk of anal cancer. All HIV-positive women, all HIV-positive men, regardless of sexual orientation, so those who are HIV-infected through injection drug use may be at risk. Anybody who's got disease on the outside is at risk and should be considered for screening, and that is why we suggest people with perianal condyloma being considered. And then people who are immunosuppressed for other reasons, such as solid organ transplant. The benefits of screening are shown here. We think if people are proactively screened, if they're caught early in their natural history, which we hope will happen increasingly, it'll be easy to treat them with TCA if the lesions are small. But even if they're in their mid to late natural history, it's relatively easy to treat them with the infrared coagulation. If they are so late in their natural history that there's nothing much we can do, we do believe there's still benefit to monitoring them to detect the early development of cancer if you can't get rid of all that high-grade disease. And this is why we say that. There is an entity called superficially invasive squamous cell carcinoma, where we think that if we're following people proactively, and if they develop a lesion which turns out to be in cancer, if that cancer is caught early enough, we believe that we can excise those lesions locally, just as you would a surgery for extensive anal warts. This would help to spare the patient of the typical treatment for invasive cancer, which is chemoradiation therapy, which, while often successful, also induces a lot of morbidity. This, too, has not yet been approved by any official bodies, but in 19 patients who have been treated with local excision for these very early cancers, none thus far have died of their cancer, and almost everybody was able to avoid getting the radiation and chemotherapy, or RAC. So if the patient cannot be treated to remove their high-grade disease, it may be an option to follow them carefully and then aggressively treat a cancer if a cancer occurs. Very important to continue to follow the patients even after successful removal of the cancer, since many of them develop recurrent high-grade disease and may in fact be at an increased risk of a recurrent cancer. Again, want to emphasize that this is not yet considered standard of care, but many investigators around the world are looking at this as a different approach to treating cancers. So the big question we're left with is, will screening of the kind that I've been telling you about actually lower the incidence of anal cancer? We know that we can make many of these lesions go away, but are we actually doing what we're really setting out to do, which is to lower the incidence of anal cancer? And the answer is we don't know, because nobody has actually done the study. To do that study, we would have to follow people with high-grade disease and see whether the treatment in a randomized controlled trial fashion actually reduced the incidence of anal cancer. This is something that we and others are actually actively discussing. Despite the fact that we don't have those data, there are certain public entities that have already recommended doing anal screening as a primary care approach in HIV-infected patients, such as the New York State Department of Public Health, who say that although this is a new practice that may not be routinely available, screening for cellular dysplasia is prudent and recommended. The U.S. Public Health Service anal screening guidelines are a little more measured, and they say that because of all the data that I've shown you, that one can consider it. However, they're not willing to come outright and recommend it because of the lack of the data that I just described for you. The answer to this issue, in my opinion, is to do the study that will determine if the treatment of high-grade disease reduces the cancer. So what should you as primary care providers do now, given what we do and don't know? In my opinion, everybody should have the digital anal rectal exam. I think that this is an area of growing importance, and we're training more people every year, and I would urge you to consider getting trained in HRA if you wish to provide this kind of care for your patients. I will say, however, that one should not do anal cytology screening unless you have the ability to do all the follow-up and treatment necessary. It is not ethical, in my opinion, to do a cytology test and then not have a means to visualize the lesions at HRA or refer them to a patient who has HRA and get them treated. So before embarking on the screening, you or one of your colleagues should be trained in HRA, and you need to have the requisite team assembled, including a pathologist, an anal surgeon, and people who are trained in counseling the patient so that they understand the significance of what's being done. When you do use anal cytology, we should consider using it to decide who to refer for HRA, and then refer in the order that I indicated earlier, with high-grade disease on cytology having the highest priority. So this is all secondary prevention, and the good news is that we have new methods for primary prevention, and that's in the form of the use of vaccination to prevent the etiologic agent coming on board in the first place, and that's HPV. We recently published a paper in the New England Journal showing that the quadrivalent vaccine is actually effective or efficient to reduce the incidence of the vaccine types in the anal canal in men who have sex with men. And we showed, for instance, that there was a 77% reduction in AIN in men who were vaccinated compared with men who were not vaccinated. There was about a 75% reduction in high-grade AIN specifically. So we do believe that if men and boys were vaccinated with the quadrivalent vaccine prior to exposure to the types that cause anal cancer, primarily 16 and 18, that they would have a substantially reduced risk not only of anal warts, but of high-grade AIN and anal cancer. Since the vaccine is really only preventive and not therapeutic, this means that the target age is about 11 to 13 years old to maximize the likelihood that they will be fully protected before they initiate sexual activity. However, the vaccine is now approved for use in boys up to the age of 21 routinely and permissively from the ages of 22 to 26. If you're immunocompromised, including HIV-infected, the vaccine is approved routinely up to the age of 26. So in conclusion, The infection that causes all this, anal HPV infection, is very common amongst MSM and HIV-infected individuals. Anal HPV infection may be as common or more common than cervical HPV infection in many groups of women. And AIN may be found in the same groups, not surprisingly, as those who are at the highest risk for anal HPV infection. The good news is we don't need to screen everybody. We know where to get the biggest bang for our buck, and we know what the highest risk groups are. We believe that the incidence of anal cancer is increasing in the general population among both men and women, and there are data to suggest that primary prevention may be useful to reduce the risk of anal cancer. And although we don't have data to prove that secondary prevention does so, we believe that it will, and we would hope to do the study to prove that in the next few years. If you do choose to do secondary prevention until we have that answer, that should include a digital anal rectal exam in all at-risk patients, high-resolution anoscopy for patients who have rapidly growing lesions, bleeding or pain, since these can be signs of cancer, and high-resolution anoscopy for patients who are screened with cytology, particularly when they have a high grade on cytology, but also some of the other grades of less severity if you have the ability to examine those patients. Finally, I just want to bring to your attention that we have founded a new society called the International Anal Neoplasia Society, which is devoted to all things related to anal cancer diagnosis, prevention, and treatment. And the website is shown here. We also provide courses in high-resolution anoscopy, the next one being later this month, April, in Providence, Rhode Island, and another one in August in San Francisco. More information can be obtained at the website below at www.asccp.org, and information about the society can be found at www.ianosoc.org. And I thank you very much for your attention.
Thank you, Dr. Pilevsky, for that excellent discussion on this topic, which we all need to understand better. We hope you have enjoyed today's session and have benefited from it in your clinical efforts. Please be sure to complete your CME form so that you may obtain proper credit for your participation today. We look forward to having you with us at future sessions. Thank you for your participation today. We wish you pleasant days ahead.